Jigeesha, where am I going to say if you're online? Yes, we are live now. We are live now, Jigeesha. Back to you.
Thank you, Debashis. A very good morning to everyone present here. Welcome on this wonderful Sunday morning to Sunday Musings, Shining the Light, a conversation on suicide awareness brought to you by Anubhav Positive Psychology Clinic. The reason why we have chosen this topic is because we are at the end of World Suicide Prevention Week. World Suicide Prevention Week is observed on the 10th of September every year since 2003, when this initiative was started by the International Association for Suicide Prevention, co-sponsored by the WHO, in order to promote awareness and action towards suicide prevention. According to the WHO, more than 700,000, that is almost 800,000 people worldwide, die by suicide every year. And for every person who dies by suicide, there's many more who attempt it. According to the National Crimes Record Bureau, in India alone, more than 1.39 lakh individuals died by suicide in 2019, out of which 67% were young adults falling in the age range between 18 to 45 years. These statistics are alarming, as suicide is complex. A variety of situations can make a person vulnerable to suicide, such as psychological disorders, financial problems, separation from loved ones, terminal illnesses, discrimination based on caste, race, sexual orientation, or gender identity. The list goes on. So I would like to take this opportunity to introduce to you our esteemed panelists who will enlighten us on the psychological, social, and legal issues pertaining to suicide. We have with us today Dr. Debashis, a renowned psychiatrist who has worked in various esteemed hospitals. He is recognized in India and abroad with over 30 years of experience in the field of mental health. Welcome, sir. We have with us Mr. Anandajit, Hore, WBPS Deputy Superintendent of Police. We thank you for joining us and for your tireless efforts towards keeping our city safe. We have with us Advocate Anna Malhotra, who is an independent counsel with over 25 years of experience in the field of legal practice, covering almost every aspect of the legal field. We welcome you, ma'am. And finally, we have with us Mr. Tirtha Sanyal, who is the Chief Operating Officer of the Healthcare Unit at EDF Hospital, one of the most renowned hospitals in Kolkata. We welcome you, sir, and we welcome all of you, the audience who are joining us live on Facebook. I am Jigeesha Ghosh from Anubhav, and I will be the moderator for this event. With everyone's permission, I would now like to move on to the questions that we have curated for our esteemed panel. Dr. Debashis Rai, I would now like to begin by asking you, what are the signs and symptoms of a person who is suicidal?
Hi, everybody. I'm honored to participate in this webinar. When you talk about suicide, suicide is not a disorder, neither a medical disorder, not a psychiatric disorder. It's basically a phenomenon, a multidisciplinary phenomenon with various layers which keep on ever changing with societal changes, with environmental changes, with personal changes, etc. So how do you know that when a person has a high risk of suicide is when basically when that person is expressing or threatening to harm or kill himself or herself, when the person is, looking at ways in which he can harm himself, or he can harm or kill, and maybe buying lethal agents like buying knives suddenly, stockpiling pills, maybe poisons, paying an extremely aggravated attention towards chemicals like, those room cleaners, etc. So these are the major cardinal warning signs, that can actually move a significant other, a near and dear one, towards the risk of suicide. But as I tell you, signs and symptoms pertain to a disorder according to the medical model. So this is absolutely elastic and ever changing. May change from person to person, may change in the same person over time. The other signs which are less important, maybe, but may have to be equally attended to. When a person starts giving away prized possessions, you know, maybe a Mobla pen or a Cartier watch or something, gives away that he has treasured for a long time. Starts there's a social change in his behavior. He suddenly withdraws himself from even his immediate family members, or he starts being very gregarious, extremely socializing, meeting people, old acquaintances, in a frenzied manner, as if it's the last day of his life. Sometimes, verbalizing restlessness, helplessness, you know, telling near and dear ones that, okay, I'm not important to anyone. Life is not important to me. Life isn't worth living. So, verbalizing suicidal intent, verbalizing the act of, trying to commit suicide is something which is very, very important. Then there's also this fact that this person suddenly starts, romanticizing about death. There are various philosophical treatises about death, like the Tibetan Book of Death, Egyptian Book of Death. Suddenly there's a pseudo philosophical uh, approach towards that. He suddenly starts clinging to the death phenomenon. This is again this is again a pointer. Then sudden irritability and alcohol abuse, primarily alcohol abuse, which increases suddenly after a personal loss or a financial loss or an occupational dilemma. These will all are warning signs. These warning signs are quite generalized. The warning signs in children and youth subtly differ from these signs in like in children, you'll find sudden sexual promiscuity, primarily in the older, in the youth, in the young adults, etc. Suddenly, rebelliousness, either towards the parental authority at home or towards the bosses, and withdrawal from the peers. So the list goes on endless. So this is it.
Thank you so much, sir, for illuminating us on what signs we need to look out for in order to understand whether a person is suffering from suicidal ideation or they have intent, maybe they have attempted it. So talking about attempt or even completion of suicide, my next question is for Mr. Hore. What are the steps of investigation the police need to take up upon receiving a report that someone has completed suicide?
Good morning, Jigeesha, and very good morning to all the other panelists. Well, first of all, I want to congratulate you for taking up this topic, a seemingly morbid topic on a Sunday morning, but nevertheless, which is a very important topic and, needs a lot of rumination. Well, first of all, what I would say is suicide, I mean, that's the end, of a process. I mean, what Dr. Roy was talking about, and normally it doesn't happen suddenly, and maybe the person who ultimately commits suicide gives out such signs beforehand, and which maybe people near and dear should be able to pick up. And like as we say, like policing is about prevention and detection of crime. So in this case, it's imperative to prevent it from happening rather than investigating it. And maybe we also have a lawyer on the panel here, so maybe she would like to throw some light on the legal aspects of it. I mean, in short, in a nutshell, if I may say so, the Indian Penal Code, particularly Section 309, has criminalized attempt to suicide. I mean, obviously, someone who's already committed suicide cannot be punished. But then again, we have the Mental Health Care Act, which came into force in 2018, which sort of attempted to counter the punitive aspect of Section 309 of IPC. But contrary to public opinion, Section 309 of IPC is still very much in place and has not been repealed. But what I may say, I mean, in my short career and as far as I know, I've talked to various officers about their own experiences. Currently, the police do not really, lodge a complaint against a victim of a suicide attempt unless someone lodges a complaint. If someone, who's related or who has been affected by that attempt lodges a complaint in a police station, the police normally, again I use, do not lodge a suo motu complaint in this case.
All right, thank you, sir, for letting us know, because I don't think a lot of people are aware that these mechanisms are actually in place. And since you did mention about laws, and we do have Ma'am Malhotra with us today. Ma'am Malhotra, could you please enlighten us on the recent laws regarding suicide?
Good morning, Jigeesha. Can you hear me? Am I audible? Okay. So, yes, as Mr. Hore very correctly put in, and he has done almost half my job, but so taking on from there, you have already curated a few questions for us. Now, the issue is that what happens if somebody attempts to commit suicide, and what happens if somebody actually commits suicide? Since the since the decriminalization part has already been spoken about, I will not dwell more on it, except to say that the law in this country actually is not only about punishing the criminal. And in this case, there is not really any criminal with a criminal intent. This is a very different position of law. Therefore, law in India also is about rehabilitating the person concerned, even in other criminal matters. So, taking from there the much needed amendments of the Mental Health Act came in, and finally in 2017, which took effect in 2018, the attempt to suicide was decriminalized. Here, as Mr. Hore very correctly said, normally the police these days do not lodge any case against the persons who are the family members or the workplace colleagues of the person who has attempted to commit a suicide, unless, of course, somebody comes up and lodges a complaint. The amendment of law actually has stressed on the fact of a stressful life and care and rehabilitation of the person concerned. The language specifically goes that the appropriate government shall have a duty to provide care, treatment, and rehabilitation to a person having severe stress and who attempted to commit suicide, to reduce the risk of recurrence of attempt to commit suicide. So at the end of the day, this is a welfare law for the person. Now, the question of what are the resources? The resources are very well laid down in the Mental Health Act itself, that says that it has to be care, treatment, and rehabilitation. Because as Dr. Ray very specifically pointed out, suicide or the tendency to commit suicide always has a psychological issue behind it. So simply punishing the person has never helped it, even in all these years. So even though the section that the IPC has not been repealed, the Mental Health Act has taken care of the same. Now, secondly, what happens if somebody attempts to commit suicide, then goes back into normal life, and there is some kind of social stigma attached to the person, or there is harassment at workplace or social life. Now, for this kind of harassment, the person concerned can always approach the police under the laws of several laws of harassment. There are multifarious laws of harassment which can be taken, which do take care of this issue where a person is harassed once they go back into normal life. This is where the attempt to suicide is concerned. But suppose somebody commits suicide. From there on, the family members, the people at workplace, they can face very, very serious criminal charges of abetment to suicide. This is a far more dangerous situation, a more grave situation for family or friends or anybody in the social circle. But however, there have been many instances where a person may have left a suicidal death note, accusing somebody of being responsible for their suicide. But now there are several Supreme Court judgments which have come up to say that even if they leave a note accusing of somebody, it does not directly mean that that person is actually the accused. What has to be proved is that the person had a direct instigation to which resulted in the suicide. Some kind of behavior instigating the person to commit suicide, or creation of such situation and such saying something so deliberately where the person's complete moral self-respect breaks down and the person has no other option but to commit suicide. So this has to be proved before somebody can be accused of abetting suicide just on the basis of a note left by the deceased. So this is a very gray area, because here the whole issue then depends upon circumstantial evidence. And circumstantial evidence in our law is one of the most difficult things to prove or to disprove. So this is one thing which everybody has to remember, that if actually a suicide takes place, from there on a criminal case begins. And for that, what is very important for both for the state and otherwise, it is important to prove that the person who is now the accused of abetting the suicide has actually caused some such action whereby the deceased was forced to commit suicide and had no other option but to commit suicide. So this has to be proved very clearly before somebody can actually go on and be accused and be penalized for that. This is one thing. And other resources, I think, is before somebody actually commits suicide, if that somebody notices that there is a tendency to commit suicide, the most important thing is treatment. Because of a stigma in our society, most people avoid treatment. So treatment and care is the only thing which is available to the family, and also to identify, as Dr. Ray has very well expressed, they have to identify and take care before rather than take care after, because the aftermath of a suicide can be very dangerous.
Yes,
Thank you, Jigeesha.
Thank you, ma'am. You have raised many important points in this one answer that you've given us. And the next questions that I'm about to ask are all connected to these points. Dr. Ray, before I come to you, there's a small question I have for Mr. Sanyal, which is, I would like to ask you that if a patient who's admitted in a hospital were to try to take their own life or engage in self-harm in any way, what steps are taken?
Good morning. First of all, thank you very much for inviting me, and good day to others as well. Okay, as a general routine in a hospital, it's the duty of the hospital for general safekeeping of the patients, all type of patients, not only mentally ill patients. So we take adequate care in any case that the patient should not take any adverse step towards their own life. So we see typically in a hospital, there will be lot of sharp objects lying around everywhere. So it is mandatory like scissors, knives and blades and things like that. So it is mandatory for the floor supervisors and the nursing superintendents to see that those are safely kept away after being used. Okay, one thing. And even bandages and other things which can be used as ropes are also kept in a separate compartment where those are not easily accessible. This is one thing. And we also make sure earlier, I am talking in particular about the hospital I take care of, we had windows without any grills. But after some incidents in some other hospitals, we have decided to put grills on the windows as a further safety for the patients. And last but not the least, if we find, see, normally a mentally ill patient will not come to a general hospital. But what happens? A typical patient after a long period of illness might become frustrated and may become a mentally ill patient. So in that case, if we can anticipate in such a scenario, we keep special watch and special nurses on duty to see that they do not deviate from their normal routine. And the last thing is, and if some cases actually comes in, like for I've seen people like suicide cases who are people who have actually taken multiple doses of sleeping pills and things like that. We after the initial treatment, we take care of the patient, we admit the patient, and we also inform the local police station because this is necessary. So if there is a further, sometimes the patients do not survive. So if we report to the police before, it actually helps the family, and even if there is a survival, it helps the family to cope up with the post effect of the suicidal attempt or in the unfortunate case of death also. So you see, in a hospital, we try to take care and see to it that no untoward incidents takes place, and we maintain all safety measures to see that this is prevented.
Absolutely, sir. So not only is there supervision available, there's also many structural changes that can be implemented in hospitals to make sure that these unfortunate events are not happening.
Yes, and you'll also see that most hospitals have their own uniform. The reason, apart from maintaining a discipline, the reason for this uniform is, see, sometimes there is a tendency of patient walking out of the hospital because it's not only we should not think about suicide only. It's otherwise also a patient normally doesn't want to stay in a hospital. Hospital in any case is not a nice place to stay. So this uniform actually identifies the patient. So the security guards downstairs can see, okay, this is a patient which is coming out of the ward. The security guard actually can stop the patient, inform the security supervisor or the nursing superintendent, and immediate steps can be taken to rectify the situation. So as you correctly said, infrastructural development is also nowadays. CCTV is another essential item which is a must for all hospitals, so which takes care of the patient. We cannot of course put it right over the patient's bed, that is not authorized or legal, but at a reasonable place where you can keep a watch.
Right. Yes, sir. Understood. These things are very important for us to remember.
Yes.
Dr. Rai, I would now like to ask you, what are the treatment or intervention options available for a person who has attempted suicide?
There are three letters, L, M, and F. L as in locus. Locus means the person who has attempted the suicide and is surviving. You know, immediately you'll have to probably take care of his physical issues, the damage that has been caused physically uh, by the suicidal act. You know, the if it was by trying by hanging, if it's by the pills. You know, the medical. There has to be a completely comprehensive medical workup and intervention. Simultaneously, we will also have to work at the patient immediately while we are doing the mental intervention, while we are doing the medical intervention, that what was the reason of that? You be with the patient, you know, start before sympathizing with the patient, you start empathizing with the patient. Sympathy is feeling for the patient, empathy is feeling with the patient. Try to earn the patient's trust, you know, and please make it absolutely clear to him that you are with him in this, in his fight of flight. Second thing that you have to do is to negate all sorts of negative consequences that the patient is going to face, either from the family or from others or from media, etc., uh, because of the act. This may actually complicate and actually increase the possibility of a later suicidal attempt. Then comes our, you know, a para-suicide biography, what we call a para-suicide biography. That is, you have to find out how, why the patient committed, at which temporal perspective, that is, at which perspective of time or situation had goaded the patient to do this. What was his immediate family environment? What was his work environment, or you know, vocational environment, either whether he was studying or whatever it was. What was his status of joblessness, etc. And mind you, it's not the situation, but how the patient perceives himself in the situation that's important. You know, the same situation in two employees, they get sacked. One tries to commit suicide, the other starts looking for another job. It again depends on emotional resilience. Then you start, there are various rating scales that we have to find out about whether there is a further risk of suicide, about the severity of the attempt, whether even after the failure of the completed suicidal attempt, whether the patient still has a possibility of committing suicide. This again this can be rated. You know, this is absolutely computerized, and it's been classified as mild possibility, moderate possibility, and severe possibility. And the stigma has to be there. You know, one of the things that we have to reiterate throughout, and the stigma is not only in India, I've seen the stigma in the West and everywhere. You know, suicide is caused most of the times due to a psychiatric illness. And all psychiatric illnesses are medical disorders. In fact, major depressive disorder is the commonest medical disorder in India. One of the studies around 4 years or 5 years ago stated that India has the highest incidence of depression in India. Probably India is the depressive capital of the world, amounting to about 38% of all depression in the world. So we should not actually, you know, tease out psychiatric disorder, so-called psychiatric disorder, from medical disorder. Any person who walks into a hospital, you know, with a heart problem, while he is in the hospital, may develop depression. Any person who's on steroids in a hospital may develop a psychiatric disorder, which may give rise to suicide. So it's as early as the better, and the earlier all the health, you know, personnel start reducing the chiasm between so-called mental illness and medical illness, the better it is.
It's a complete workup, basically. You look at
Yes,
the patient
it
from
is
a
a
medical.
multidisciplinary workup.
Absolutely, absolutely. And a follow-up to this, is there any kind of support that is provided to the family, children, spouses, parents of the people who have attempted or died by suicide?
This is a different question altogether. It's a very easy question, a long question. The answer demands a very long answer. This a person, people who have been treating people treating suicidal survivors, mental health professionals. It's a very thankless job. Uh, it depends. Normal grief, a person who's mourning a natural death or maybe an accidental death due to a vehicular accident or a road traffic accident, that grief has a lot of sympathizers. But in case of a suicidal survivor, of, of a close relative, of the immediate family relative of a person who has committed suicide, they are judged in a different light by their immediate society, by their neighbors, etc. They feel that okay, and so when they are judged in a different light, as if suicide is something which is a contagious phenomenon. So these people start, apart from the shock that they have had, apart from the grief that is going to follow, apart from the denial which comes along with this, they have a fear of being ostracized by the society, especially in developed countries, especially when in suburban and rural populations, where the social education about suicide is much lower. So the first aspect is a psychoeducation, in whatever form. Psychoeducation which that person who's a suicide survival understands in his or her own terms. These terms will again be differ from one age to other. Psychoeducation for children would be different from the psychoeducation of the parent of a suicidal or completed suicidal, right? So, the language differs, the mode differs. Again, they start blaming themselves. They start attaching themselves to the suicidal act. You have to tell that person that, look, it's an act which has been committed by a person who was under certain mental state at that point in time or around that point in time. Right. It is not your creation. For example, parents start blaming themselves that, okay, I haven't raised my child properly. If a child would be similar to the parent biologically, intellectually, emotionally, and cognitively, then a father would be a twin to his son. But that's not. There's a different biological component completely in the offspring, one. And the offspring, even after the different genetic biological endowment, also has a different environment in which he grows up, apart from the parental environment, and also has a different interpretation of that environment, which may sometimes, if it is wrongly construed, wrongly interpreted, and later on subsequently improperly, inadequately enacted, may give rise to a suicidal act. So this has to be clearly enunciated in no uncertain terms to the parents. The spouse blames, sometimes there's a romantic breakup, there's a marital disharmony, which may give rise to suicide. Again, the happening doesn't cause suicide, especially except in cases of strongly abetted suicides. So you have to look at the person's mental state. And in most cases, this person is not a mental health professional. Even sometimes you have to tell these relatives that even a mental health professional also misses suicide. When I was working in an institute as a junior resident, I had 2 successive suicides in 2 Sundays. Bolt from the blue, and the senior resident, the junior resident, and the consultant, all of us went back to our textbooks. So it's a quagmire completely. It's difficult to say.
It is very complicated to handle not only the person who survived suicide, but also their family. You were talking about psychoeducation. In case of a death, there might be...
It's not complicated. You have to have the right perspective. You have to go beyond the lines of the textbook. You have to look at the person.
May I just cut
Yes,
in
please
here?
go ahead.
Just
Yeah.
one small question for Dr. Roy. One small question. Like, could you tell us something about the death drive or thanatos and whether it has any bearing on suicide?
Very good question, sir. We have an entire science called the science of death, thanatology. Thanatos was, introduced in the mental health world by Sigmund Freud. The eros and thanatos, that concept is old hat now. But there's always a death drive, even in the most successful person. So the death drive is not intimately related to suicide. Even a person who's very much an achiever may sometimes feel that, okay, I have done so much, thus far and no further. So the death drive always may creep into that person. One. Second, in a person who's absolutely stable, physically, emotionally, intellectually, and cognitively, a sudden death in the close relatives, brings out a helplessness inside the person, about the omnipotence of death, which all probably most of us are familiar during this COVID times. So death is something which is a very interesting phenomenon, which is still undelved by science to an extent. And there are a lot of these magical religious texts, a lot of unscientific, non-scientific texts about that. But definitely, death drive may sometimes also be tutored through therapy called mindfulness therapy into a positive way in individuals who have a good cognitive reserve. Excellent question. Thanks very much.
Yes, thank you so much, sir, for this question, because I think the topic of death is in itself anxiety provoking, and we are talking about suicide. So, Dr. Rai was mentioning how hard it is for mental health professionals sometimes to be able to understand the entire case. So, I actually have a related question for Mr. Hore, that if there is a mental health professional who's working with a patient or someone who's attempted and survived suicide, and the family members lodge a complaint against this mental health professional, how do you investigate that? What are the procedures you're following?
Well, first of all, let me just say, in our country and given our system of jurisprudence, anyone can lodge a criminal complaint against anyone. I mean, today you may lodge a complaint in a police station against me on any ground, saying that I have hit you or I have harassed you. X may file a complaint against Y, saying that X was under the treatment of Y, and either due to an act of commission or an act of omission, X has gotten worse, and so we see this all the time, when, especially when patients die on the operating table or they, pass away in hospitals. At times the patient parties, as we commonly call them, they sort of go berserk, and in some cases there may be genuine grievances also, due to an act of negligence or maybe a deliberate act, something untoward may happen. And so I think this is a risk, this is an occupational hazard, which medical professionals have to take in their stride. And I believe the same applies to mental health professionals as well. But then again, let me assure you, like, even if someone lodges a complaint, the police will definitely thoroughly conduct an investigation in the most professional manner, and if no direct evidence is found to implicate that particular medical health or mental health professional, he or she will definitely be left out of the charge sheet.
Correct. All right. Thank you very much, sir. And Ms. Malhotra, I would also like to extend this question to you that if such a complaint were to be made against a mental health professional, what legal aid or legal procedures follow?
Actually, generally what happens, once somebody commits suicide, the family, as Dr. Ray very correctly pointed out, that they are constantly looking for answers of questions which probably they don't even know what the answer can be or what the question correctly is. So the issue of mental health is a very, very unknown issue for most people outside the mental health professional zone. So while they are blaming themselves, they also want another person who can probably be blamed for the same. This is an attempt to avoid the stigma as well as try and shift the blame to somebody else. In this manner, there is no separate procedure under law by which you can get any help. But for as you deal with any other issue of negligence, professional negligence in the medical fraternity, the procedure is exactly the same. You have to then put up your case properly and cooperate with the police in the investigation and explain to the police what are the medical issues here which are beyond the control of a medical or mental health professional. Beyond that, law does not provide any separate procedure for any mental health professional. This all comes under what we very commonly people say is medical negligence, because generally the accusation or the complaint is about medical negligence of not being able to identify what went wrong and therefore it caused the suicide. This is the general nature. So it will not have a separate procedure or separate defense. It will come under the same defense that comes under for all the other medical professionals.
Yes. All right. Thank you very much,
But,
ma'am.
I would also like to ask, ma'am, that is there really
Yes.
any precedent in our country of either a psychoanalyst or a psychologist or a psychiatrist being actually convicted of, not being, able to stop a suicide?
Not to my knowledge. I have not come across any such judgment or conviction orders or anything in my career, because as I said, it is very difficult in the full arena of mental health is something which we do not understand clearly at all. I can give you an example. Sometimes people approach me for matrimonial issues. I have in these 25 years become a counselor for them, their family, because there is so much. While even dealing with it from a legal point of view, I have seen there are mental health issues in those situations. Whenever I have tried to push them towards a mental health professional, only 5% people have taken my suggestion in good stride. Otherwise, they say in Bengali, "Apni ki amake pagol bhabchen?" So, this stigma coupled with the lack of knowledge has always been a very gray area. So, the law in India is always that you do not convict a person till you are absolutely sure. Even if 100 accused go free, but one innocent should not be convicted. That is the law which we follow in India. So I have not come across any mental health professional being convicted of medical negligence or being unable to stop a suicide.
All right. Thank you very much, ma'am. I would now like to move on to Mr. Sanyal. There is a question that is there any separate procedures for admitting a person who has attempted suicide?
Normally in a hospital like ours, or for that matter, any general hospital, three types of cases would come in. Normally, I have never seen in my career any gunshots coming in. Suicide being committed by gunshots. I do not know. Mr. Hore will be able to tell that whether it's very common in, at least in West Bengal. I do not know that. So the most common suicidal cases which comes in are overdose of pills, or slashing of the wrist, or hanging. So hanging patients, I have not seen many of them survive. They are always brought in dead. So in all three cases, like any other cases which comes to emergency room with any unnatural injuries, it's a standard procedure to report to the police. There's a standard form where you report. Now I'll take the example of a person who's come in with a overdose of sleeping pill. Immediately that person is taken, it is tried to pump out those medicine, and immediate treatment is given. And survival rate for suicidal attempt with overdose of pill, and if they are brought in timely, are very high, and most of them recover within 2-3 days. Okay. So next comes the slashing of wrist. Slashing of wrist, even if they come timely, the survival rate is quite high, but it depends upon the injury. And many a times we have seen the detection of patients with slashing of injury is pretty late. And as a result, there is a substantial blood loss, which makes the survival of the patient difficult. But in all cases, the patients are brought into emergency room and treated because when they come in, we treat them as a clinical patient, I mean a normal patient, because they are coming in with an injury. Now that injury might have caused because of a mental illness, so that is taken care of later. Okay, so first we have to see whether we are able to give enough support to the patient so that he or she survives. So that's the standard procedure for any other injury case. We also treat this patient similarly. And the follow-up psychiatrical treatment comes up later when the patient recovers.
Okay, all right. Thank you, sir. And I have a follow-up question for you. That how do you sensitize the staff in the hospital in dealing with these issues?
Normally, all the nursing staff, they have in their syllabus, they have a course for dealing with mentally ill patients. Okay, so that's part of their syllabus. And this I particularly know because we have our own nursing school, and we have to regularly send our students to one of the any of the mental hospitals in Calcutta. For it's about 2-3 months training. Whether that 2-3 months training is enough for them, that I do not know, but they do go through it. Apart from that, we have our own training for soft skill for any all staffs. See, this training for mental health is only for nursing staffs. But you see, there are other people other than the nursing staffs. You know, the person who actually takes the stretcher, the person who actually pushes the wheelchair. So we have to train them as well. So we do conduct on a regular basis soft skill training for this stuff to treat patients well in general, and particularly to watch out for patients who are a little bit deviated in their mind and to treat them much more carefully. We do that.
Right. Okay,
and apart from that, we also have a counselor on our panels. They make regular visit to the patient irrespective of their mental status. I mean, that's a standard procedure. Like just before in many cases, I have seen the patient's relative do not come to see the patient. So in those cases, patients become very depressed. So, you know, a counselor goes around, she talks to the patient and they feel well. So it's a standard procedure in all hospitals nowadays to have a counselor to see and feel how the patients are reacting to the longs. Particularly, this happens for patients who are in the hospital for a very long period of time. So we all hospitals nowadays try to put in all possible avenues to see that everything is taken care of, both physically and mentally.
Okay. All right. Thank you so much, sir. Dr. Rai, a question has just come in for you. How can you differentiate between non-suicidal self-harm from self-harm with the intention of death?
Self-harm itself, by definition, in our terminology, is non-suicidal.
Okay.
Right? Now, first thing is, in case of self-harm is almost always associated with a psychiatric disorder, like borderline personality disorder, impulsive behavior, substance abuse, etc. Whereas, there may be even children who are, compromised concerning their brain. They have a lot of these head banging, etc., which should also be included in self-harm, and it has been included by some of the researchers. So this is one. The second thing, practically, you should look at the extent of harm that's been done. And by definition, how would you define suicide? Suicide is defined as a self-intended, self-inflicted cessation of life. So the strength of the intention, sometimes when in a cutter, we call them cutters, in a person who slashes the wrist or something, look at the depth of the cut. If it's an self-harm, which we earlier we used to call DSH, or deliberate self-harm. In order, for propriety, we have changed it to SH, or self-harm. The cut is much more, much less deep than an intended cut, right? So there are, in case of a person who has an intended or a quasi-suicidal self-harm, there may be past history of suicide in the person. There may be family history of suicide in the person. There may have to be emergent environmental issues which can rationalize that, which is long continuing, emergent, subchronic, at least subchronic environmental issues, either in his workplace or at home, etc. Whereas self-harm is basically an impulsive act which may happen, and the modus is definitely sometimes different.
So it is a largely qualitative probe that we have to do in order to understand each case that is coming in.
It's easy for a lot of, there was a time when in corporate hospitals, we had to attend around 8 or 9 self-harm cases in a day, in half a day, I would say. Right. And not all of them, would have, a suicidal intent. Whenever there's a self-harm, the psychiatrist assesses the suicidal intent. There are various rating scales. One of the commonest one which anyone can administer is the suicidal risk rescue ratio. So which can be administered even by a non-medical person. So that will give us the possibility of that will give lead us to understand whether this person, how severe is this act, how severe is the attempt, and what will be the prognosis of this SH.
All right, understood, sir. I'm very sorry, but we are almost out of time. So I would quickly like to ask for concluding remarks from all of you, starting with Ma'am Malhotra. Maybe we can say that decriminalizing suicide is a step in the right direction. What added mechanisms being strictly in place can help prevent suicide?
I think the basic requirement is care and sensitivity. You see, our society is not sensitive to people who are suffering from anything apart from probably a physical disorder. So sensitivity, care, and early detection, as Dr. is repeating it, early detection is required, and the family needs to be counseled more, because they are the first people who support the person. So the
Absolutely.
family counseling is extremely important. Thank you.
Absolutely. Dr. Ray, I would like to ask you, what can friends, family, or us in general do for someone who is maybe suicidal or has tried to attempt it? What can we do to help them?
You know, very, very loosely speaking, if you consider suicide to be a negative phenomenon, you can never replace negativity with neutrality.
Very rightly
I
said.
would always say that, replace suicide or any negative phenomenon, negative medical phenomenon with at least an equally positive or a more positive substrate.
Right.
One of the things is definitely encouragement, move on. One of this accept that act as a natural phenomenon, as sunrise or sunset, nothing beyond that. Because if you put, there's no gain if you keep on reading too much about that very suicidal act or the person. One, positive mental health. I believe Anubhav has been espousing this positive psychology for a long time, and positive psychology is the call of the day. Even sometimes physical exercise, regular physical exercise, regular mental exercise. It's very easy. Anyone can do that every day. So these are going to definitely take you a long way in fulfilling your life.
Thank you
So
very
I
much.
would like to look beyond suicide.
Yes, I think you put it beautifully, accepting the act as if sunrise or sunset in order to be able to move on is so important for us to understand. So thank you for summing it up so beautifully. Mr. Hore, I would like to move on to you and ask you, do you have any advice for the ones who have lost someone due to suicide or are, have suicide survivors in their family?
Perhaps you or Dr. Roy or Devlina are more better equipped to answer this question. But I can just say one thing, and I will say one thing, that if I may quote Sadhguru. I mean, I recently heard one of his talks, and he was saying that we look at this, we look at that, we attach value to a lot of materialistic things, but the greatest phenomenon happening around us is life itself.
Yes.
So, and perhaps the strongest instinct in us is that of self-preservation. So, for someone to actually, go beyond that and actually end life, that is indeed a horrible thing, an unimaginable thing. Obviously, context here matters. Someone who's in abject poverty, you know, someone who sees no light at the end of the tunnel, a student, whose parents have always been goading him or her into, bringing home good grades, and maybe they rebuke him or her unknowingly when somehow the grades go down, and a fidine or a suicide bomber who blows himself up with his suicide vest and kills others in the process. So, all these are acts of suicide, but the contexts are entirely different. So it's a complex thing, but I would just say this, that, if you are uh, a theist, if you believe in God, if you believe in a higher power, then maybe even if you don't, I mean, you should, believe in yourself and believe in your self-worth. And there's this responsibility uh, which we have as a society in general to look out for each other, our friends, our neighbors, our relatives, and maybe, uh, especially in these uh, times of the pandemic, call people, Tumi kemon acho, how are you doing? I mean, even if we cannot materially help them, but at least a soothing word, a hi, a hello, that we are there for you, it can work wonders and, go a long way in preventing suicide.
Thank you, sir, for saying that. A simple question like camo nacho can actually save lives if it comes to it. So thank you so much for pointing that out. And Mr. Sanyal, the last question is for you. Since we are talking about the stigma and so much taboo, what can we do as a society to prevent suicide or become at least more aware of these things?
To answer this, first of all, I'd like to say what Dr. Roy said a few minutes back. You see, before that, you all said you had statistics that most of the suicides are in the age range of 18 to 45. So it's pretty young generation who actually commit suicide. The numbers are high. So I would assume those are children and they have their patient. Now I refer to what Dr. Roy said, like children would not be clone of their parents. So is the pressure put in by the children, by the parents to the children, sometimes leads to this kind of tragedy. So the parents, this is for this age group, the parents should particularly be connected to the children and their sons or daughters, whoever, and see to it that they are aware of all their activities in good times, bad times, everywhere. And in other cases, like Mr. Hore said, simple question, Camonacho, makes a lot of difference. It does, because nowadays every family is a very small family, and we hardly have large families as my parents used to have. So in their system, they could always fall back on their jattu, didi, to the pichi, and goes on and on. But in our case, is we stay in small flats, and is only and the next possible family is, say, a long distance away. A phone call or a small talk also helps. And last but not the least, see, like any other illness, mental suicide comes from mental illness basically. So like any other illness, physical illness, this is an illness and this needs to be treated. And so my advice is everyone should go to the professional when they are in need of this type of help. And I can tell you from my personal point of view, I had actually gone to Anubhav when I had some problem about 10 years back. And Anubhav really helped me. And I still today send many people to Anubhav for and you have to get that stigma out. Just going to a psychiatrist or psychologist doesn't mean you are bad, because you do not have a fallback system. So this is my advice, and I think if we can jointly work together as a community, as a neighbors, as a friend, we can help actually people to come out of these suicidal tendencies and prevent much more suicide.
Thank you so much, sir. Absolutely, you spoke the absolute truth. This is how we have to look at mental illness, not as something that is dangerous or we can't approach it, but something that we have to accept and help those who are suffering move on. So I think there is nothing left for me to say after hearing all of you speak. Suicide, as we have established, is not the only choice a person has. Everybody has the right to live a happy and healthy life. Suicide is preventable, and there is help all around us. We just need to reach out, show kindness to ourselves and to others. We have now come to the end of the show. Thank you so much, panelists, for taking time out of your busy schedule and joining us today and sharing your views on this extremely important topic. This was indeed an enriching session. I myself have learned a lot, and I'm sure the audience has learned a lot from you too. Thank you, Ma'am Paromita Mitra Bhumi, for giving us this platform. Thank you, Ma'am Devlina Lahiri, for your technological support. Last but not the least, thank you, audience members, for your enthusiasm. We are signing off today, and we will see you for the next one. Thank you.
Thank you.
Thank you very much. Thank you.
Thank you.